Good afternoon, everybody. Today, my topic is review of X-ray and ultrasound. So, in this, I would be covering basics of chest X-ray, ultrasound in pregnancy, and some part of ultrasound in acute abdomen. So, chest X-ray, we all knew there are different views for the chest X-ray. So, moving forward. PA, posterior anterior view, that is PA view, which is the most frequent used view in the X-ray, chest X-ray, and it is mostly used for the lung pathologies. Lateral view is used in adjunct with the PA view, and it is mostly done to assess retrosternal space. Generally, it is approximately 2.5 centimeter. If it is less than that, then we may diagnose emphysema, and more than that we get any anterior mediastinal masses. So next is AP view. We all know that it is done in ICU patients or the bedside X-rays, portable X-rays. If we suspect rib fracture, we can use this because the posterior aspects of the ribs are more clearly visible in this view. Lateral decubitus view. Also, in critically ill patients or the patients who are not able to stand, we can use this. So you can see, we can diagnose small amounts of pleural effusions in this, or the intestinal obstruction for the patients who are not able to stand. Oblique views are generally used to visualize retrocardiac areas, costophrenic angles, pleural plaques, chest wall lesions, or the rib lesions. Expiratory film is generally used to visualize pneumothorax. Inspiratory expiratory paired view is generally used to demonstrate the air trapping in cases of foreign body. Now the landmarks, normal landmarks, we all know this is the trachea, central. These small things are the spinous processes of thoracic vertebrae. This is the bifurcation of the trachea, that is the carina. These are the hilum, right and left hilum. We can see the pulmonary arteries in these, right, left. These are clavicles. This is costophrenic angle. This is cardiophrenic angle. This is costophrenic angle. And these are the diaphragms. Now, how to interpret the chest X-ray? Let's go one by one systematically. Let's start with confirmation of the name, age, sex of the patient, whether you are seeing the X-ray of the same patients, which name is written on the X-ray. Then clinical presentation of the patient, determine whether it is PA view or AP view, determine whether it is taken in full inspiration. In full inspiratory film, you should be able to see the diaphragm at the level of 8 to 10 posterior ribs or 5 to 6 anterior ribs. Then how to count ribs? So we all can identify first rib in the X-ray. This is the first rib. Below that, you can see the second anterior rib. Trace it posteriorly up to the spinous process and then count downwards the rib. Then it is third, fourth, fifth, sixth, seventh, eighth, ninth, 10th. This is how we count rib while the interpretation of the X-ray. Check for the penetration, whether it is a properly exposed film. In normal properly exposed film, you should be able to see first four spinous processes, thoracic of the vertebrae. More than that, then it is a overexposed film. Less than that, it is underexposed film. Check for the rotation. In normal film, the clavicle, heads of the clavicle are equidistant from the manubrium sterni, and decide the side of the X-ray. We all know that the left gastric bubble we see on the left side. So that's how we can decide. Now then, look for the trachea, whether it is central or deviated. We can get deviation in cases of masses or pleural effusion, etc. Look for the subcarinal angle. Generally, it is 60 to 75 degrees. More the angle, you can see in subcarinal pathologies like lymphadenopathy, mass lesion, left atrial enlargement, or pericardial effusion, etc. Look for the heart. Look for the size and shape of the heart. Look for the cardiomegaly. We actually generally look for the cardiothoracic ratio. If it is less than 50%, it is normal. More than 50% of the cardiothoracic ratio, that is the transverse cardiac width divided by the transverse thoracic width. If it is more than 50%, you can diagnose cardiomegaly on that. Look for the mediastinum, again whether it is central or deviated. Look for any opacity in that area. Look for the pleural spaces. Visualizing the pleura in this fashion, will help you not to miss any small region related to the pleural area. Lungs, again, visualization in this fashion helps you not to miss any small area of the lung, any small opacity in the apical ridges or the costophrenic angles, etc. Look, compare the compare the translucency on both sides, that is the blackness, or look for vascular markings and the opacity, that is the whiteness. Look for the hilar prominence, any mass in the hilar region, etc. Also, see the diaphragms. Look for the outline, shape, tenting margins of the diaphragm. This is right, this is left. Generally, right is upper than the left hemidiaphragm. In lateral film, you can see the right hemidiaphragm is continuous posteriorly, while the left hemidiaphragm is silhouetted by the cardiac shadow. That's how you decide right and left hemidiaphragm on the lateral view. Also see the area below diaphragm for the free gas under the diaphragm in cases of perforation peritonitis. Look for any abnormal calcifications. Also see for the soft tissue shadows and bones for any fracture, any abnormality in this area also. Moving towards some common pathological conditions I have covered. First is consolidation. Generally, we can decide classify consolidation on the pathological basis, that is alveolar or interstitial. In alveolar consolidation, alveoli is normally the air in the alveoli is replaced by the abnormal materials like pus, water, blood, etc. In interstitial disease, the scaffolding around the alveoli, this interstitium is inflamed, is pathological. Maybe it may be inflamed, fibrous, or edematous. So it generally presents as diffuse consolidation, while alveolar generally presents as lobar or segmental consolidation. So lobar consolidation. It is generally a density limited by the fissure. Generally, there is no loss of volume, there is no shift of mediastinum in consolidation. The air bronchograms, you can see these black branching markings, which is the air in the bronchus. The alveoli are filled with the water, but in bronchus there is air. So you can see the air bronchogram within that opacity. This is the hallmark sign of the consolidation. You can see this in pneumonia. Diffuse consolidation, in this you can see ill-defined radio opacities in bilateral lung fields. It is generally not restricted by the fissure. You can see this ARDS, CCF, or bronchopneumonia. Alveolar consolidation generally presents as fluffy shadowing, airspace opacity, ill-defined margins, and it is mostly segmental or lobar, like I earlier said. And in diffuse consolidation, you can see this reticular nodular shadowing. It is generally seen in viral or fungal mycoplasma pneumonia. Coming towards the pleural effusion, we can see the homogeneous density in pleural effusion. The most common and the most common sign is the meniscus sign in this. There is loss of costophrenic angles and cardiophrenic angles. You cannot see this in this pleural effusion. They are generally blunted. But again, it depends upon the amount of pleural effusion. Then there is loss of cardiac and diaphragm silhout. The silhouts are gone. Approximately 200 cc of the pleural effusion will cause blunting of costophrenic angle on PA film. While on lateral decubitus X-ray film, you can demonstrate even smaller amounts of pleural fluids. Generally, 1 millimeter thickness equals to 20 cc of pleural fluids. Now the atelectasis or collapse of lung. Again, in this you can see the homogeneous density, but here there is a shift of mediastinum. So in consolidation, there is no shift of mediastinum. In pleural effusion, there is shift of mediastinum or trachea, but towards opposite side. And in atelectasis, there is shift of mediastinum or trachea, but to the same side. Look for the elevation of diaphragm, drooping of shoulder, crowding of ribs, and compensatory hyperinflation of the opposite side of the lung. In bronchitis, you get prominent bronchovascular markings. They are more on the lateral 1/3 of the lung field. Generally, normal bronchovascular markings don't reach till that area, but here you can see they are reaching till the lateral 1/3 of the lungs. Pulmonary edema, you see typically bat wing airspace shadowing. This perihilar distribution is generally called as bat wing shadowing. There is prominent interstitial lines, including curly B lines. In cardiogenic pulmonary edema, you can also see cardiomegaly, and also you can see the cephalization of pulmonary veins. I mean more drainage of the pulmonary veins in upper part of the lungs. Tuberculosis may have varied appearance. You can see the fibrocavitary lesions like this in apical part of the apical and upper zones of the lungs. You can see reticular shadowings like this or interstitial consolidation. In some cases, you can also see pleural effusions also. We all know tuberculosis heals by the fibrosis, so you generally see fibrous scars in the healed tuberculosis. You can see the shift of trachea because of the atelectasis or the collapse of the upper lobe in the X-ray. You can also see pulled up hilum. These are typical signs of healed tuberculosis. Pericardial effusion, this globular heart, this shape is typical of the pericardial effusion. This is generally called as water bottle heart. You can see upper zone vascular prominence, and you can also see the pleural effusion here. Again, the difference between consolidation effusion and the atelectasis, we already saw there is a trachea central in consolidation. In effusion, it is pushed to opposite side. In atelectasis, it is pushed in the same side. There is air bronchogram in consolidation. You don't see that in the other two conditions. Meniscus sign only in pleural effusion, not in other two conditions, and loss of volume in atelectasis, not in consolidation. If there is underlying lung collapse in pleural effusion, you can see that in effusion. In pneumothorax, you can see hyperlucency on this side, you can see, and there is underlying lung collapse here and here. You can also see the collapsed lung margin over there. This is pneumothorax. There is generally shift of trachea towards opposite side here. Hydropneumothorax, similar loss of lung markings, underlying lung collapse, hyperlucency, and the opacity with typical air fluid level. In emphysema, there is hyperexpansion of the lungs and there is flattened diaphragm. Generally, the diaphragm should be here, 7th rib anteriorly cut the diaphragm in the between. However, you can see here flattened diaphragms. Neoplasm can represent it in varied formation. You can see rounded mass lesion, you can see multiple mass lesions, cannonball appearance, and this snow stop appearance in some metastasis. So now moving forward to ultrasound in pregnancy. First, dating scan. It is done in 7 to 10 weeks, generally to determine intrauterine or extrauterine pregnancy. Generally done for the viability, and if the patient is having bleeding PV, it should be always done. NT scan, it is one of the most important scans nowadays. It is done in 11 to 13 weeks of the gestation. Benefits are assessment of risk for trisomy 21 and other chromosomal defects. It detects the major abnormalities of the heart and great arteries, again to check for the viability and accurate dating of the pregnancy. Also to detect multiple pregnancy and identification of correct chorionicity at this level is possible. What is seen? We do NT scan when there is CRL of 45 mm to 84 mm. Even if the gestation is by dates 11 weeks, but the CRL is not 45, we generally do not do. NT is measured, nasal bone is seen whether it is present or absent, and ductus venosus flow and tricuspid regurgitation are looked for the aneuploidies. Raised NT can indicate fetuses with chromosomal abnormalities like trisomy 21, 18, and 13, Turner syndrome, triploides, cardiac defects, genetic syndromes, etc. At this stage, many major anomalies like anencephaly, here you can see, crania, neural tube defects like this, encephalocele, or the limb anomalies, absence of limbs, and that you can visualize. What is combined testis? We hear a lot of times combined testing. What is combined? In combined testing, along with maternal age risk, NT scan report, and serum double marker test, a combined risk for the chromosomal anomalies is calculated by the use of software. This is called as combined testing. If the risk in this result is high, then an invasive testing for the chromosomal anomalies advised, that is chorionic villus sampling at 11 to 14 weeks and amniocentesis at the 16 weeks. It is generally determined, it is used to determine the chromosomal pattern of the fetus. Once we get the chromosomal pattern of the fetus and that is positive, the decision of continuation of the pregnancy can be taken by the patients. If some patients misses NT scan, please advise NFT scan at 16 weeks. Again, we do NFT and quadruple testing at this level, and risk is calculated for the chromosomal disorders. Anomaly scan, again one of the important scans, that is done at 18 to 22 weeks of the gestation. Primary objective is to do detailed anatomical evaluation to identify severe and lethal abnormalities and to raise the suspicion of abnormality. What is seen? Of course, all the anatomical structures, including brains, face, spine, etc., are done, thoroughly examined. Gestational age is again determined by the biometry. Amniotic fluid assessment, placental assessment, and umbilical cord assessment is also done. What is not seen? Many patients ask about development of brain. माझं बाळ बरोबर आहे ना, त्याचं इंटेलिजन्स चांगलं आहे ना. सो नो, वी कॅनॉट प्रिडिक्ट द इंटेलिजन्स ओव्हर हिअर. मॅडम सगळे सोनोग्राफीचे रिपोर्ट तर नॉर्मल होते, मग बाळाला हँडिकॅप का झालं? सेरिब्रल पाल्सीचं जे हँडिकॅप आहे दॅट वी कॅनॉट रूल आउट अँड दॅट वी कॅनॉट को रिलेट विथ द नॉर्मल इंट्रायुटरन अल्ट्रासाउंड्स आणि हँडिकॅप कॉज बाय दी सेरिब्रल पाल्सी ड्युरिंग बर्थ और आफ्टर बर्थ. Also, some anomalies like TO fistula or imperforate anus they may not be detected even after repeated scans. Now, fetal cardiac scan. Generally, it is done at 24 to 26 weeks. It is a specialized scan carried out by trained personnel. A detailed examination of the fetal heart and connecting vessels is carried out. Result gives, if the result is positive, if there is any anomaly, it gives parents and doctors ample amount of time to prepare for the emergencies at birth. Also, some developmental anomalies which are not seen in anomaly scan at 18 weeks, we can rule out at the cardiac scan, or this is the delayed anomaly scan we can say. It has the indications of cardiac scan. Maternal diabetes, autoimmune diseases, use of some certain drugs, CHD in mother, assisted reproduction because they are the precious pregnancies, first trimester rubella infection. Fetal indications are history of sibling with the cardiac defects, prominent NT or raised NFT, fetal structural defects in other organs, infections, IUGR in mid-trimesters, persistent fetal tachybradycardia, major extracardiac anomaly, or monochronic twins. It also has some limitations. Some lesions such as very minor VSD may not be detected at all. Progressive defects such as bicuspid aortic wall may not be diagnosed at 18 to 20 weeks or till 24 weeks also. And maternal habitus and fetus lie, obviously there are limitations. Fetal well-being scan done at 28 to 32 weeks to assess fetal well-being, growth, estimation of fetal weight, evaluation of placenta, liquor, and fetal movements. We can do very well 4D scan at this stage. Fetal Doppler scan. It is again one of the important scan. It acts as an antepartum surveillance. It is a non-invasive method to study fetal dynamics, fetal hemodynamics, and it gives a guide regarding frequency of follow-up with timely intervention. It has benefits. It obviously reduces the incidence of fetal death to detection of hypoxic and acidemic infant. It also minimizes the morbidity by optimizing the timing of delivery, and it identifies the fetus that are genuinely at risk of chronic hypoxia. First trimester Doppler, obviously we screen both the uterine arteries, which helps us to detect at risk patient for the development of PIH and FGR, fetal growth retardation later in pregnancy, and ductus venosus Doppler acts as a screening tool for aneuploidies. Now, again, indications are diabetes, chronic renal disease, maternal disease, autoimmune diseases, and fetal IUGR, reduced movements, and so on. 4D ultrasounds, nowadays it helps in lots of things like surface, to see better surface detects. You can see the club foot over here. In gynecology also, it helps in better delineation of the uterine malformation. You can see septate uterus, biconate uterus very clearly here. In infertility, ultrasound also, it acts as a better high-end one-click technology to count all antral follicle volumes in the ovary with just one click. Nowadays, in abdominal ultrasound also, it helps to better delineation in renal and this is ureteric calculus and bladder calculus, clearly seen. Some cute photos of babies. Now in radiology in acute abdomen. In acute abdomen, you can advise abdominal X-ray in your OPD setup when you suspect small bowel obstruction, perforation, foreign body, or renal tract calculi follow-up. Done, I'm done. You can see this is the large amount of air below the diaphragm. It is indicative of pneumoperitoneum. Small air fluid levels, multiple air fluid levels indicative of intestinal obstruction. Abnormal dilatation here, a small bowel and large bowel. More than 3 centimeters small bowel, more than 5.5 centimeter large bowel, abnormally dilated. It also has some pitfalls. So ultrasound becomes the modality of choice in acute cholecystitis, appendicitis, appendicular perforation, obstruction, ureteric calculi, ectopic pregnancy, if you suspect ovarian or testicular torsion, and also in intussusception. So widespread availability, low cost, and absence of ionizing radiation makes ultrasound a choice of evaluation of acute abdomen. It is a choice of modality in pelvic disease, and it is a primary test even if we require CT or MRI later in pregnancy. Thank you so much.
In X-ray, first topic was dedicated really to the general practitioners, how to read X-ray at various disease conditions. And the second topic was on ultrasound. The part of it is dedicated to gynecologist, and second part was dedicated
Many
to
of the
surgeon.
practitioners do
Surgeon. I think you explained everything very nicely.
Thank you, sir.
And highlighted of reading X-rays and ultrasound. Thank you very much.
Thank you, sir.